was more referring to the North American prom. The prom, that's a school dance. So Hujur, you get this gift. Okay, the next gift, it's an interesting question, but it's a little bit tricky, but you may not need to Google. It's twice the gift than the first one. What is prem? Love. Who is saying love? There you go. So we are dealing with school dance and the gift. Can anybody have a look at it? Like, oh no, means does it show up? Okay, so this is from high school dance. It's a big deal in North America. And this is prem. This is big deal in our country as well. So, but what I'm trying to bring in front of you is prom means patient-reported outcome measures, and prem means patient-reported experience measures. So today I don't have any results, I don't have anything. The only thing I have, I came here as a preacher. I want to preach to you guys to think about prom and prem, which we already know in this context, so that the way we look at medical research, health service utilization, health system functioning, outcome research, and all those things with the lens of prom and prem. And they both are funny things. Okay? So, what do we mean by outcome research? Outcome research, in simple form, is the research that is concerned with the effectiveness of health services. We all provide service to patients. We all do lots of interventions. So outcome research looks at how good they are, how much they are making a difference. Traditionally, we have been looking at measures such as health status. Did the patient die or not? Recovery or not? How many people we treated? What was the treat number? How many patients we treated? So all those angles in cost effectiveness and disease burden, like number of people treated, number of people recovered, dollar amount saved, measures of disease burden of different types. Traditionally, we used measures, they are definitely important. But on the other hand, we miss out how the patient is doing in terms of, their life, their way of living and everything. So there is an increasing awareness around the globe. The treatments, interventions, rehab should be clinically effective, economically efficient, but also acceptable and desirable to the patient. The patient's life is in stake. We should be ensuring that the patient's life, the quality of life, or any other aspect of the living is being considered when we are looking at this prem, prom, or outcome research things. So this is called patient-reported outcomes. The patient's voices, the patient's views of their life due to some treatment, due to something that we are intervening upon. It is based on their perception, like how the things are going. And then unlike traditional clinical outcomes, the patient-reported outcomes, PROs, give us unique insight on how a therapy can affect a patient, how an intervention can affect a patient, how some medications can affect a patient. So the ability to measure a well-being. So we are moving out from hard outcomes or number-based outcomes toward a well-being outcome. And these are important in the clinical situation as well, because health is a holistic concept. And rather than treating the disease alone, I think we need to move up now towards treating the human being who have the disease in or her body. We have come a long way in terms of treatment, but probably we have not done that much in terms of this approach of well-being in different disease scenarios. So PROMs and PREMs, so this patient-reported outcome measures, patient-reported experience measures, these are tools of measuring how the patient is living a life. We have tools, like we have this excellent data in administrative database of National Heart Foundation. How many people treated? How many people recovered? How many went home? But we normally generally miss out how well they're doing. And that should be a part of our day-to-day routine activities. Now, there are existing tools, quite a bit of tools. You may have heard lots of research being done. As a researcher, when I go to do research in community, I use lots of scales: quality of life scale, hospital anxiety scale, mental wellness scale. I'm using them, but they are confined within the research only. We are missing out the opportunity to bring those tools into our day-to-day practice, where those will be the guiding beacon of understanding what else, apart from correcting the disease condition, we can do. So PROMs or PREMs, as I say, there are quite a bit of scale, and we can use those for different diseases in different conditions. Cardiovascular disease, PROMs and PREMs around it will be a little bit different than the cancer disease. Or within the cardiovascular disease, the biggest impact of the PROMs and PREMs will be in the cardiovascular rehabilitation, because that is beyond this treatment of intervening on something, but a longer horizon of time where we are going to improve people's different aspects of the life, including the physical abilities. So we definitely need to come up with, and we hope, I'm preaching, I'm begging, I'm putting my hands on to think about these things as we as a collective move forward in Bangladesh. And also we should not be just bring Western standards or Eastern standards or any standards directly to us, because the PROM and PREM have the beauty and the challenge, so that we need to tweak, adapt, and give them a Bangladeshi root, the Bangladeshi flavor that will be appropriate for the communities that we belong to. The basic parameters are there, but there are work needs to be done which tweaks everything. The Chinese food we have, we all love the Bangalianized Chinese food, right? So this PROM and PREM need to be the Bangalianized one. And the only way of doing it is we do it. And it's not like, reinventing the wheel or starting from the scratch. It's more of a calibration, modification, qualitative studies, and bringing all those aspects in. And we can do it at home. So there need to be strategies in this one. An example of different PROMs that can be used in the cardiac rehabilitation scenario: definitely we need to follow up with people of health-related quality of life, patient satisfactions, physical functioning, mobility, activity of daily life, all those components, psychological states, how they are doing it, symptoms which are directly not observable, and then social functioning and treatment adherence. Lots of time we miss out the point, the treatment adherence is a direct byproduct of the social functioning or the social norm or other components that defines people as people. So how to interpret measurement methodology is very important, because we may collect data of the PROM, but if we don't have the context based on which the scales we have developed or tweaked or calibrated, we will be always misjudging people's movement across the life and across the different level of diseases. And we need to do it at home. It will be different from gender, because in our country, we have a very big gender difference. In our country, we don't have big sex difference, but we have a very big gender difference. Again, I'm just poking the envelope, because sex and gender issues are such a huge issues, and the gender is a social construct. Again, who are doing these things, like trained people doing it PROM, because if I am doing it, to a woman, asking her about the sensitive type of information in our culture, will miss out on getting the real answers. So those things, the calibration and adaptation and execution plan, that has to be totally Bangalianized. So way to move forward, I think I am just putting this one in because fortunately in Calgary, I was part of the team who in 2014 did a prom and prem forum, and where the conversation started. So in 2021, there is a health quality council in Alberta. They have adopted this and is trying to promote that every physician, primary care physician, or in the health sector, they utilize those things as a part of their, waiting room scenarios. The people, they will be asked, and this one doesn't need to be done by the doctors. This one can be done by the treatment team, and that team need to be defined by us and our groups. So what we did, we started reviewing the Prem and Prom. Well, we identified the need of Prem and Prom based on the current context of ours. We evaluated the theoretical and conceptual frameworks, and then we worked with a group of patients. And patients' involvement is so important to modify, sensitize those Prem and Prom to the ground level reality, and then employ those measurement tools. And then the other things happens, right? If you employ measurement tools, you collect data, you evaluate as we go on, those common things that go on. But the starting point, doing it in a good way, is important. And as I said, different diseases have different, combination and, flavor of the Prem Prom. So hopefully we in this National Heart Foundation can take it on, focusing on cardiac rehab, somewhere to start. First baby step, and one baby step at a time. Oh, so, okay, so what? Okay, sorry, it was a mistake. So Prom and Prem, these are small words, but the depth of this one is big. And we need to now move also, means treating people is, we are doing, and things will be improving. But, well-being of the people is so important. And without that, the problem is I get treated and I go back to the same environment where I got the problem. And then what happens? I come back here. I was listening to a couple of senior members talking about the recent environment of Bangladesh of, high energy drinks. They are seeing below 40 people getting heart attack, and asking them, the information came out, in a day they take 4 to 5 high energy drinks. Again, these are Prem Prom related components that we need to incorporate, figure out, and do it. And the time is up. Thank you, guys.
Thank you, Dr. Tanvir Chaudhary, for a nice presentation. Our next presenter, Professor M. Atikul Haq, Head Medical Division, Medical Statistics Division, Department of Public Health and Informatics, Bangabandhu Sheikh Mujib Medical University.
Distinguished audience, respected chairpersons, and my colleagues, good evening. Actually, today I would like to present different types of research finding of our team, and hopefully after my presentation, every person may think about this. That is the association between childhood adversity and non-communicable disease among adults in later life. To find out an association between these two topics, that is childhood adversity and NCD, is not a very straightforward. CDC and Kaiser Permanente, they conducted a study in 1995 led by Vincenti Felletti and Robert Anda. Initially they reported 17,000 data from their healthcare staffs. And they found very interesting finding that is almost every NCDs are related with early childhood victimization. As you know, that the early childhood victimization is a very stressful and traumatic experiences, and it comprises several items. Felity and Anda, they developed a questionnaire or tool based on these 10 items, that is physical abuse, psychological abuse, sexual abuse, physical neglect, psychological neglect, depressed and mentally ill household member, domestic violence, parental separation, incarceration, and addict household member. These 10 items and these 10 events that will be happen, that must be happen before their age 18 years. And these 10 items has remarkable health impact in their future life. Faleti, when they developed this tool, they scored this tool from 0 to 10. And every one abusive event or witnessing abusing event, they scored 1. And here the 10 events. So these tools scored 0 to 10. So why should we think regarding this SC and NCDs in Bangladesh? As already it is established that early childhood victimization is very much related with the development of non-communicable disease in the later life. So we should think that any kind of NCD, its root lies in the early childhood of that children. Why it is important in Bangladesh? According to WHO, the overall mortality rate, that is 67% mortality, is now related with NCD. And at present, approximately 24% people of Bangladesh, adult people of Bangladesh, are suffering from hypertension, and 12% diabetes mellitus, and all others NCDs are very high rate at present in Bangladesh. Faleti, they found this interesting finding, that is, if one person have AC4 or more, they have the risk of 3.4% risk to develop lung disease, that is COPD, 2.2 hours to develop heart disease, 1.9 hours to develop any cancer, and 1.6 hours to develop diabetes mellitus. How this happen? Actually, any kind of adversity during early childhood produces some sort of toxic stress. This toxic stress disrupt our stress mechanism through some epigenetic changes. This altered stress system increased inflammation, impaired cellular immunity, which accelerated immunosenescence. And that is the really risks for psychiatric, cardiovascular, and chronic inflammatory diseases. So at present, what is in our hand? We already conducted 4 studies. That is one, the mother's adverse childhood experience and elevated risks of neurodevelopmental disorder in offspring, a case control study. We have already published this paper in Adversity and Resilience Journal. Association of adverse childhood experience and type 2 diabetes mellitus in later life, a case control study. The impact of benevolent and adverse childhood experience on adults' mental health, a cross-sectional study, and adverse childhood experience and intimate partner violence, finding from a community-based survey in Bangladesh. And this is the alarming picture. That is, almost 97% adult people in our country experience maltreatment or witnessed violence, and which is supported by our recent some recent studies that we got more than 97% children in Bangladesh experience any form of abuse and neglect. So this graph represent the how many our study people, our study participant experienced childhood adversity. And this is the most promising finding which we may think for future prevention model. That is, mother having more than 3 ACs are fourfold vulnerable to give birth to NDD offspring. Persons experiencing SCs more than 4 are 2.2 times prone to develop type 2 diabetes mellitus. Our third paper was related with SC and mental health problem. That is, we found the significant association between SCs and depression, anxiety, and stress. And here we found the significant risk factor. And another one thing that is, we examined that female having more than 4 SCs are victim of intimate partner violence. And this is the gist of our 4 studies. So what is, what is at present, I can say you that AC is the major concern of our public health. And we found a very dose response relationship of AC score with health consequences. So my recommendation for all policymakers and all work of peoples that to prevent for any kind of prevention program, we should think from the very beginning, that is the childhood. Without exploring, without maintaining childhood well-being, actually it is totally impossible to control non-communicable diseases from the society. And what we are now doing, that is, we are now doing a molecular genetics and epigenetic mechanism behind this scenario. And we conducted, this study is now ongoing, and we are doing this research with collaboration with Dhaka University, Bangabandhu Sheikh Mujib Medical University, and Bardem. Thank you.
Thank you, Professor M. Atikul Haq. We have the discussion and audience interaction after we have completed all the presentation. Our next speaker, Dr. Ruhul Abid from Brown University, USA.
Thank you again. Thank you, the organizers and distinguished panelists, chairperson, and the audience. So I think we're almost at the end of the session. So my talk would be regarding integration of preventive and tertiary cardiovascular healthcare in Bangladesh. And though it's a big title, but I'll not propose any solution, just I'll show that what we are doing from Brown University, and we have a health and education for all an organization based in Bangladesh, what we have been doing and how we are trying to solve some issues here in collaboration with DG Health Services and NCDC line director is here. So I'll just share some story how we are trying to help rural populations and connecting them from the very beginning, from the very rural place to the Upazila Health Complex, then district hospital, and preferably to tertiary care centers. So this is the same disclosure I just presented. I have a few NIH grants, and I'm a scientific officer and consultant for a few startup pharmaceuticals. But those are not related with this work, because what we'll be presenting is mostly kind of a voluntary work so far. Anyway, so this is Brown University I showed earlier in the same hall. And so why and how? So I'll tell you as a story rather than a solution, like share my experience, like how I started and why we are doing it, and how, maybe I don't know why I'm doing it, but I know how we are doing it. So I graduated from Dhaka Medical College, then went to T States because I marked it red because that red color means it's played a significant role in my career. Though I'm doing like a cardiovascular research, I did in Japan, then USA, but still that 3.5 years experience actually gave me a lot of confidence that I can do something like this. So I think anywhere the lesson number one is here, because I saw that some older people say what to take home and what kind of lessons. I think I almost reached that level. So the lesson number one is wherever we are posted or private, government, try to do our best is important. Try to do the best for the patients, for the surroundings, for your friends, families. That's very important. So then after 3.5 years, I went to Japan, did my PhD in genetics and molecular biology, then went to USA, did a fellowship in Louisiana State University Medical Center, which is a southern part of the USA. Then I went to Harvard Medical School, did a fellowship in cardiovascular medicine, and then for 2 years, then become a faculty, worked there for almost 12 years total. And then 2011, I moved to Brown University, and where I am now since then. So that's the story. And then we were thinking, though we are doing a lot of work in the USA, and the when I became faculty at Harvard Medical School, that time it started like what we can do for Bangladesh. So what is the major concern, like the cardiovascular diseases, non-communicable diseases. So that's what our target is, and I'll present what we did there. So as I shared before, but that was a different session. So this is like you can see that NCD, the non-communicable disease death burden, is quite different. Like when you have 1 to 29, it's like 2 million out of 11 million deaths due to NCDs. But when the age group is from 30 to 69, it changes totally. So it's like 14 million out of 20 million die of NCDs. And then 70 plus is like almost 90% deaths are for NCDs. So that's very important. That's why we started doing it. And this is the actually the panel most important for when I started at Harvard Medical School in 2008. Actually, first we thought about it. You see that Dr. Rosemary Duda, she came in 2013 and 15 with me, started this work. That time we didn't have electronic medical record system or anything with us. So we did the paper-based. Then when I moved to Brown, you all know Dr. Frank Selke. He works with me for this cardiovascular component of this work. And we call it Health and Education for All. So it's registered in the USA, also in Bangladesh, in NGO Bureau. And Dr. Susan Kubin, some of you may know, she comes every year 2-3 times to do cervical cancer screening. And Dr. Jane Carter in the middle, she is the main person for tuberculosis. So she is kind of, I'm not an expert in non-communicable disease. So she helped, she came 2 times to Bangladesh, even went to Rohingya refugee camps, inaugurated the tuberculosis conference in Dhaka. So she's the ex-chair of president of Tuberculosis Union. Okay, so in 2013, when this Rana Plaza, so we were planning a lot of things, but nothing was done. But 2013, when there was Rana Plaza incident, so we first came to Bangladesh to see what's the health status of the garment factory workers, because it's very important. This is the major source of income, even now, for foreign currency for Bangladesh. So this is the initial team. You can see there is Alpert Medical School, which is Brown, then Harvard Medical School, MIT, DMCH, SMC, and local medical doctors and students joined together, and we did screening. At first, we did screening to understand what type of diseases are there in the garment factory, because there is no data at that point for the garment factory workers. And the left side, you can see that my daughter was, I think, 9th or 10th grade at that time. So she came with us, and she came many times. And there are a lot of faces you may know. They are now, some of them are consultants, some of them are FCPS, some of them are in the UK. So those are the young doctors and students who worked with us. And this is a group which performed almost 5,000 garment factory workers health screening and follow-up for NCDs, hypertension, diabetes, asthma, in 2016. So that was like a 5-month project. And what we do is, like, we have 4 stations. So one is station 1 is, you can see that they measure height and weight. Station 2 is blood pressure and heart rate. Station 3 is, there are 2, station 4. So the left lower one is station 3, where they measure blood glucose and hemoglobin. Station 4 is the doctor's doctor consultation. So every data actually transfers from tab to tab, that electronic, and then it opens in the doctors as a summary. So doctors tab shows the summary, and if there is any raised blood pressure or raised blood glucose, so it will tag, and then they can ask them for follow-up. So this is in brief how the electronic medical record system, which is called NIROG, means good health and no disease, works. Briefly in schematic, you can see that the government worker is there. So the data entry. Then first is, as I showed, that health worker will measure height and weight. A BMI will be calculated automatically in that tab. And then that data will be transferred to the next tab, which is the next station. It can be done in the same tab also, but for convenience, we are doing thousands of garment factory workers. It's large-scale screening on site during their work. So it was very difficult to convince the garment factory workers. So we had to move fast, and that helped us. So the second is blood pressure, heart rate. Third is blood glucose and hemoglobin. So next is the doctor station, and then you have the prescription there. They perform some examinations, and these are all ICD-10 code based diagnosis. Then the prescribe and give a card which can be scanned and used as a follow-up. So this is a real setting of a garment factory workers. So far we did 40,000 garment factory workers in Dhaka, Baluka, Mymensingh, Narayanganj, Savar, many different places. And these are done means like we followed up them for at least 1 year for treatment. And then when the Rohingya refugee, actually the FDMN, forcibly displaced Myanmar national, they are called here. So that influx happened in 2017, 25th of August. So we collaborated with the DG Health, and they had 26 centers. So out of that, the two largest one, the Kutupalong and Balukhali, which actually we have still been collaborating with DG Health with that. So we started this electronic medical record system using solar panel. So this is Wi-Fi router enabled, Nirog in the Rohingya camp. You can see initially there was no electricity and internet. Even now there is no internet, but we are still having all the data recorded. So that solar panel charges on the right side. You can see the battery. That battery gives charge to the Wi-Fi router on top of the table, and the laptop works as a server, and that connects all the tabs within the center. And Professor Dr. Robed Amin actually visited that, so he witnessed it firsthand. And then, so this is the tab. It can take picture and generate a scanning barcode, and that you can use for follow-up. They can come back with the follow-up. And this is the brief height, weight, that how it looks in the tab in real life. And this is the summary, which actually doctor sees when patients passes through all the stations. And this is briefly what I showed earlier. Is the same. The data connected with, and it's going to Wi-Fi, then going to, you can send it to iCloud, and it connects. You can connect it with the DG Health's MIS server. So the major plan we are doing is like the community clinic and the sub-center, Ipojala Health Complex, district hospital, and tertiary. So initially we are planning to move the data, not the patients. But if the patient has some kind of a high risk factor, suspected hypertension, diabetes, or other chronic diseases, then they can go to the Upajala Health Complex and seen by a doctor, confirm diagnosis, and then they give the medicines. They may take it from the community clinic. At this point, there is no, they have to take it from the Upajala Health Complex, but later we can, in the NCD corner, Professor Dr. Robed Amin actually established very well-established NCD corner. So we visited in Chandpur, Noakhali, and Cox's Bazar, Kurigram, many different places. So this is the cardiovascular risk chart, which can help the community clinic personnel and Upajala Health Complex. And these are just, I'll not go through due to lack of time. You can see that we also now have a semi-automated climate-controlled NCD path lab in Cox's Bazar. So this is like we can have very high quality data from their reliable sources. So we have some help with the foreign experts, and you can see that this was inaugurated by Professor Dr. Robed Amin in 2021 December. So, and this is a recent visit. Our Haifa team, I think Dr. Samia Tasnim is here. You can see she also visited the center, and our Dr. Sharmin Sultana and our country director, they all went and we visited the center recently. And another thing we did actually, DMCH cervical cancer screening, like a training center with the help of UNFPA. We worked for last 1 year and last couple of sessions. So now they're established center. You can see Professor Dr. Susan Kuvin there. So They can train all Upazila Health Complex nurses, midwives for cervical cancer screening. It's a colposcope, mobile colposcope, which is also digital. So it's see and treat, just single one-stop service. So in Kurigram, we are doing 9 health complexes. So not only the center, we are also training the Upazila Health Complexes in the rural places. So this is 6 Upazila Health Complexes in Cox's Bazar. And these are just some pictures. I think I'm almost out of time. So that's actually, in a nutshell, that what we are trying to do is initiating the screening at the community clinic level, which is village. And then if you see something there, then they are transferred to the Upazila Health Complex. They go there and confirm the diagnosis and then get the treatment from Upazila Health Complex. Later, if we can give it from community clinic, so that will be great, because there are many rural places where patients cannot move. Like in Kurigram, Burungamari and other places, they need to cross 2 rivers. And if they start at 6 in the morning, they reach the Upazila Health Complex around 10:30 or 11. So its whole day is gone. So I think that's it's very important that we have the electronic medical record
more
system.
time, sir?
Thank you.
Time?
No, it's fine. So just I'll be done. So Upazila Health Complexes as a NCD corner, as Professor Dr. Robed Amin and we discussed earlier, that would be work as a hub, and then from community clinic we'll transfer the data and get the back referral also from the. So this system, Nirog, has also the back referral system. It has some drug interaction kind of mechanism. It can flag the drugs when, if someone is getting some drugs and become pregnant, it can flag that this is there may be a significant risk. So with that, I'll stop. Thank you very much for your patience hearing.
Thank you, sir. Thank you, sir, for a nice presentation. I would like to request Dr. Nina Islam, Director, National Center for Control of Rheumatic Fever and Rheumatic Heart Disease, to come on the dais and take a seat for this chairperson. Yeah. Yes, ma'am. Thank you. Our next speaker, Tom Johnson from UK. His title is Looking Beyond the Intervention.
Thank you. And this seems fairly trivial following the previous presentation. So at the same time, I think maybe there are some similarities of message, which is about looking beyond the focus that we all have on intervention and thinking how we might be able to make a bigger impact. So this is titled Beyond. Javier has already mentioned maybe it's before, it's all around. We have to think about that. Those are my disclosures. I'm going to, in typical interventional fashion, share with you some Kaplan-Meier plots first, because that's where we're most comfortable. But actually, there's a reason for doing so. And this is a recent study that we participated in and actually recruited over 100 patients to the Firehawk Target All-Comer study, which was led by Microport, a Chinese stent company, comparing this bioresorbable polymer, or fairly novel design, sirolimus-eluting polymeric stent, which within a month or 2 becomes a bare metal stent. And this was a head-to-head comparison against Xience. And importantly, this followed out to 5 years. And we're just in the process of finalizing the 5-year manuscript. But Alexandra Lansky presented the 5-year data at the ESC. And the reason for wanting to show you this is I think it highlights that there is a lot more beyond the intervention we need to focus upon. I'm very proud that this was really an all-comer study. We recruited, as I say, over 100 patients. And what's interesting here is to see a higher prevalence of diabetes than we would in our normal population of intervention, which would roughly be in the sort of 15 to 17%. There are a tremendous number of acute coronary syndrome patients recruited, which is much more a reflection of our practice, which actually in the UK, as Keith Oldroyd showed us yesterday, is in the order of about 70% of our intervention is in fact acute coronary syndrome. And these were complex lesions, 80+% B2C complexity with restenosis, total occlusion, bifurcation, complex 2-stent, all included in this study. If we look at the composite endpoint at 5 years of cardiovascular death, target vessel myocardial infarction, ischemia-driven TLR, then actually it's not bad. We have an annual attrition rate comparable in both the Firehawk bioresorbable polymer versus durable polymer Xience stent, 3%-ish. If we break down the revascularization need, then actually there's a relatively low level of problems related directly to the stent. We see that within target vessel, there's an ongoing need for revascularization. But if we consider beyond target lesion in total, so both other vessel and target vessel, we see over 2/3 of intervention is actually away from the stent that we focused our original index procedure upon. And the reason really for sharing this data is this slide, which I think is truly concerning, showing that at 5 years, a composite POCI, patient-oriented clinical event rate, is over 30%. And I'm not sure how many of us consent our patients at the time of an intervention to say that there's a 1 in 3 chance you're going to come back either dead with a heart attack or needing further revascularization, or if you're really unlucky, a stroke in the next 5 years. But that is the reality of what we're treating in the interventional community. And I worry that our focus is very much on the procedural element, and it drops off as soon as the patient is discharged. Now, at the moment, we're working on quite a unique data set in Bristol, which enables us to bring together information from our GP colleagues, from the mental health, from community services, alongside the healthcare data sets, which gives us really quite a novel insight into the patient's ongoing journey, not quite touching proms and prems, but at least giving us a handle on what's happening to our patients once they've left our direct care. So we have about 1 million population in Bristol, but if we consider then the attributes and the activity tables, we now have many millions worth of data to potentially drill down upon. So very crudely, if we just look at acute coronary syndrome in Bristol across a 3-year period, just over 5,000 patients, we see the impact of COVID with a drop-off in the non-STEMI rate, but actually the STEMI rate remained remarkably stable. If we break down that into cost, and we said cost was one measure that we might be interested in, but this is really quite revealing that of those 5,000 patients, an annual cost is looking in the order of about £8 million. So per patient, that's about 554,000 taka. But most worryingly, once they leave hospital in the next 12 months, the additional costs, and the blue line is costs just in hospital. The green line is community, the yellow line is prescription costs, the orange line is primary care engagement with nurses, with GP doctors. The unexpected emergency costs related to these patients coming back into our care unexpectedly is another £6.5 million, another 456,000 taka per patient. Now, the reality is actually it's not per patient, because that cost is localized to a very small number of highly comorbid and complex patients that we probably could have identified up front. So 50% of the cost is in fact sitting just with 12% of the population. 25% of that cost is actually with just a very small 4% of our population. And currently, embarrassingly, I don't think we're able to identify and intervene upon those patients in terms of addressing their needs, addressing the inequality of access that they might have. So we've looked a bit more at this, trying to understand those costs and coming back really to those patient-observed clinical event rates that we saw in the target study. And so we can see this bright white flare of cost that's incurred when the patients first come into hospital when they're treated with their infarct. But actually those ongoing, unexpected, non-elective costs across the next 12 months persist. Now, we egotistically might think, well, that all must be, bystander disease. But actually, if we start breaking that down to individual areas of the hospital, we see actually that the burden of cost is in elderly care medicine, is in general internal medicine. These are patients returning with bleeding or with stroke or with heart failure related immobility. These aren't patients requiring our care again, and consequently, these aren't patients that we are aware of. They're not visible to us. So we believe we've done the excellent angiographic result and we've saved the life when we move on. But actually, these patients continue to return. And one might argue that many of those patients maybe we shouldn't have intervened on in the first place, because these events will have occurred regardless of whether we stented. And so actually, I believe that this is really impactful data for thinking carefully about the appropriateness, beyond appropriateness guidelines, but actually practical appropriateness of conversations with patients about what will make a difference. The Atal Gawande kind of impact of being mortal. Now, having heard Professor Narula's data on lipids and the Egyptians, and we were really interested in looking at lipid control because it's something we can impact on and maybe change. And so we've looked just in the first 12 to 18 months post-discharge from their index admission. So when the patients first presented with their heart attack, about 20% were on high-intensity statins, 20 to 30% on low intensity, and the majority on no statin. When they left hospital, so this is GP prescription level data, we would believe that 80, 90, 100% of our patients are on 80 of atorvastatin, but actually, even at the point of discharge from hospital, about 60%. And there really isn't any change in terms of up titration across that 12-month period. A very, very small number are accessing the inclisiran that was mentioned in terms of this engagement we've had at a national level in terms of access to new and hugely exciting lipid-lowering agents. So there's more that we could do. Now, even simply looking at this fairly crude data from our experience, we can see outcome difference. So this is actually a composite of net adverse cardiac events in our community. We can see that high-intensity statins do make a difference, but worryingly, we're seeing actually a significant increase in adverse outcome, even in those persisting on a low intensity, and especially those on no statin. Now, we have to question why they're not on statin, and that's something we need to better understand, and part of that is about engaging with patients and understanding the challenges. Now, that leads us back. I just thought historically we look at courage, the gold standard that's thrown at us in terms of optimal medical therapy, that medical therapy was as good as PCI. If we actually look, and impressively, they have managed to capture the ongoing ability at preventative lifestyle change. And if we look at this, and this was alluded to by Professor Narula, actually only about 20% achieve lipid-lowering levels. You can see that across the 5 years, despite these patients recruiting into an aggressively controlled study, their LDL cholesterols remain above target in the majority. And, sorry, just a moderate activity. We talked over dinner last night. Patients continue to smoke. Patients don't lose weight. BMIs remaining in the 30s. Exercise only of 30 to 40%. If we consider medication, there's been a lot talked about adherence, and this was a hugely impactful study that has in many ways been overlooked from the ESC by Valentin Fuster, showing that the use of a polypill, questioning really this ability of adherence for patients against usual care, we saw a significant enhancement of this composite of death, non-fatal MI, urgent revascularization. And in the supplementary appendix, actually, we see a significant improvement, a 33% relative risk reduction in cardiovascular death, just simply through taking one pill against the unlikely adherence of 3 pills. And we've heard about the impact that inclisiran, other PCSK9 inhibitors might have. This is really exciting work from Lawrence Raber's group, demonstrating how we can potentially quiesce, we can silence plaques, thicken the fibrous cap, reduce lipid pool, and potentially avoid subsequent events. Now, it was mentioned about cardiac rehabilitation being an important aspect. We invite all our patients to rehab. 40% fail to attend. We don't truly understand why. And yet there's really impactful data highlighting that exercise, moderate activity makes an impact. One of the issues I'm quite interested in working upon is we have this fantastic free access exercise program in the UK, now attended by over 1 million of the general population, probably the wrong million, but attending on a Saturday morning and running or walking a 5K park run. And I'm trying to embed this into a novel program of rehabilitation exercise. So beyond intervention, we have to consider looking beyond the extant angiographic result. We have a responsibility to understand what's important to our patients and then better understand where the challenges are in terms of them being able to access the care they require and comply with the medications we think are doing the good. And there's a huge amount of further work that we must do, and we must act now. Thank you for your attention.
Thank you. Our Professor Soil Rita Choudhury, Professor and Head, Department of Epidemiology Research, National Heart Foundation Hospital and Research Institute.
Well, I'll be talking about current epidemiology and initiatives to control hypertension in Bangladesh. And I must admit that some of the slides you might have seen in the earlier session before lunch, Professor Fazila Malik's presentation. But I'll try to be brief and try to focus on other issues that we are doing on. So the outline is I briefly talk about epidemiology, and then we'll talk about Bangladesh hypertension control initiatives. And then we also talk about our efforts for reduction of salt intake in Bangladesh. So as you may know, 70% of death in Bangladesh are due to non-communicable disease. And among this, and 30% is due to cardiovascular disease. But as Professor Malik also pointed out that large number of deaths, that's around 40% of cardiovascular deaths are actually premature in Bangladesh. And we know that hypertension is one of the top 3 risk factor that is contributing to the disability adjusted life year lost, which is found by the Global Burden of Disease study. So hypertension control is one of the important aspects where we can actually reduce the complication of hypertension, also reduce the premature mortality. But what is the situation in Bangladesh for hypertension? This is the hypertension cascade as developed from the WHO national representative data from the WHO STEP study. It was done in 2018 among almost around 10,000 population selected from all over Bangladesh. And we found that the prevalence was 21% in the age 18 to 69 years. And so if we extrapolate these 2 numbers, we have about 20.9 million hypertensive in Bangladesh. But as you can see, only 10.2 million are diagnosed. That is, only half of them are actually diagnosed. So we have a serious problem of detection. So detection is a problem. And among those who are detected, we have only 7.8 million on treatment. That is 35% is actually under treatment. And among those who are treated, we are only 14% are actually under control. So you have a very serious problem of detection problem and also a treatment problem. So if you want to control hypertension and prevent this premature cardiovascular death, we need to actually reduce this detection rate, increase the detection rate and also increase the treatment rate also. That is the control rate. So this is an important slide that clearly shows that if we try to intervene in the community to reduce premature death by risk reduction of different risk factors, like changing the lifestyle, anti-smoking, weight reduction, salt intake reduction, this will take a lot of resources. But the green line shows that if we can take all this intervention, we can reduce this premature mortality very sharply. But if you select only one intervention that can have very high impact, that is the hypertension control, the pink line that is showing. If we can just address the hypertension in the community and increase the control rate, the premature mortality in South Asian population, we can reduce it drastically. And there are some economic analysis also. And a paper published by World Health Organization with World Economic Forum, they have estimated that if we scale up the CVD drug therapy, which can prevent about 0.5 million of, 0.5 million deaths per 1 year in Bangladesh. So with this background, we actually, in collaboration with government of Bangladesh, that is NCDC program of DGHS, a National Heart Foundation, with a grant from Resolve to Save Life, we have initiated the Bangladesh Hypertension Control Initiative. We call it BHCI. And Professor Fazila Malik has also shared this experience, but I'm going to briefly talk about it. So what was our objectives, we actually established the universal screening. As we said that we have a problem in detection, so we don't have any screening program in Bangladesh for hypertension and diabetes. We established a universal screening program at the facility level, that is in Upazila health complexes or sub-district hospital, and each and every patient who is adult patient coming to hospital for any other consultation or visiting relative, they can get their blood pressure measured in hospital by nurses. Then we train the physician and then train the physician to use a simple treatment protocol. And like 3 drugs, we have selected 3 drugs. Government actually selected 3 drugs like amlodipine, losartan, and hydrochlorothiazide for hypertension control, hypertension treatment at primary care level. And then we actually talked with, sat with government and NCDC to ensure the uninterrupted medication supply, because this is the important strategy. And also we are trying to do the decentralization of refilling, decentralization of medical drug distribution. Then we have introduced, our objective was to introduce a simple app on medical digitalization of the record keeping that can help a patient record, and also have some monitoring. For monitoring purpose, we can see how our facilities are performing. Then we also have one component of the campaign in lifestyle changes, and for we also have a research center of excellences. So we, as you know, we started in 2008 in 4 upajilas, now expanded to 54 upajilas, and now in this year we are actually going to start in 180 upajilas in collaboration with Non-Communicable Disease Control Program. So this is the 5 components that we have established, that we have a consistent protocol. All doctors are trained with this protocol, medication supply, and these are actually components of WHO HEARTS package that we are implementing. Community-based treatment, that we are using community clinic to drug refilling, also screening. Patient-centered care, nurses are taking measure blood pressure, and also they are calling them if they don't come back. And we have a digital information system. So this is we are actually working with government under an MOU with Ministry of Health, and that is DGHS. And what we have done, we have trained our project staff, almost 51 project staff. We have provided training to the various levels of healthcare provider in government service, and also we have provided training to the doctor, nurses for using simple app that you are using. As you can see in picture, we have a tab given to the nurses who can actually enter data and register patient in the simple app, and patients are given a passport, green passport, that is called BP passport. And we also working in the community, giving training to the community clinic healthcare provider, and for blood pressure measurement, and also for actually awareness creation through community clinic and community support groups. So these are visit by dignitaries, but just some of the indicators. We have almost 133,000 patients registered till today, and the control rate, as I've said, is now hovering around 57 or 59% in 54 upajilas. But we have a problem of 14% BP uncontrolled and 28% misvisit. And when we investigated why people are not coming back, we found that people are not coming back because of the distance. So now we have initiated giving drug from the community clinic in select divisions. So these are our next plan. We are expanding to 180 sub-district hospitals in 22 districts of Bangladesh. So these are the BHCI, but we have also have some research issues along with this program implementation. We have recently published a paper on the estimation of the cost of this program, and we have found that most of the cost actually related to the procurement of medicine, essential medicine technologies, and we have found that annual hypertension medication cost per patient in our program area is about $18 per year. So this is a bit high. So we need to address this issue, and because we have a large number of patient pool to address. Besides this, we also recently done one survey in Bangladesh, and we wanted to know the burden of pregnancy-induced hypertension. And through a grant from Niport, we have done a facility-based survey of pregnant women and found that the pregnancy-induced hypertension is quite high. It is 10.1%, and we have identified some determinants from like higher age, inadequate fruits and vegetable consumption, and higher MUAC actually associated with pregnancy-induced hypertension, and these are shared with Niport. This report is shared with Niport, so they can take some policy initiative for control or to address this pregnancy-induced hypertension. We also are working for salt intake assessment in Bangladesh. We have done two surveys, one in 2012 and one in 2018, using 24 hours urine from community, and we have found that the salt intake has not just decreased. It's about 9 to 10 grams per day. And now we are trying to develop a simple formula from where we can, from a spot urine, we can actually predict the actual salt intake. So yesterday, Mr. Saim actually presented the new formula in our conference. We are writing a paper on it, but we have actually estimated, we have seen that the formula, these are not which are available now, are actually not appropriate for Bangladesh population. So we are now developing a new formula. And we also assessed the salt content of the processed food in Bangladesh. We know that most of the salt that we are taking are coming from discretionary salt that is added during cooking but in tables while taking meal. But a large portion of Bangladesh are also taking processed food, and the day by day the processed food industry is growing. So one of our research was to see the content of processed salt in our processed food. We have collected samples from all over the Bangladesh and analyzed them in a good lab in India to estimate the process salt intake, salt content, and we found that most commonly used processed food like chips, chanachur, they have very high salt content, and if you compare it to the UK traffic light system, none of the brand have the healthy level of salt content. So we need to actually address this issue also through policy level. And the level that they are showing on their product actually underreporting the content. Most of them are underreporting the salt content. So there should be a good leveling, and also the content should be, standard should be set by BSTI or Food Safety Authority for salt content of the population. Apart from these, we are actually doing several other trials with Johns Hopkins University regarding, we are evaluating the WHO Heart's hypertension control package. It's a quasi-experimental study. We are looking into the incidence of dyskalemia in patient giving with, initiating FDC with telmisartan and amlodipine. And also we are trying to do an evaluation of the use of telemedicine in screening and detection of hypertension by CHCPs with the advice from the medical officer from the Upazila through telemedicine. So these are the few studies that we are trying to do in next couple of years, and hopefully next year I can come up with some more result on this. So way forward, we need to have a very strong government support, and government actually have a very I would say in our multi-sectoral action plan, we have the line director here. They have a target of strengthening 200 upazilas for this NCD corner for hypertension service delivery, and we are actually working with government for strengthening these NCD corners. And government also procured the, for study for our project, we initially bought all the BP machines and all Armin machines. Now government is actually buying their own machine and supplying to the whole 200 upazilas. And I thank Mr. Robert Amin for this initiative. This is a huge initiative by government. And also maintaining adequate medication supply is another issue, because we have seen that if there is a stock out and the control rate goes down, so we are actually working with government to how to ensure the uninterrupted medication supply, and the decentralization of supply from community clinic is an important step, and we have started working on this issue. I think that's it. Thank you. Thank you, well.
Uh, thank you, sir. Due to time constraint, we would like to skip the question and answer session. Directly go to the discussion, comments, and conclusion from the chairpersons. First of all, I would like to request Madam to initiate.
Assalamu alaikum. Okay. Good evening. I'm very much honored to be a part of this conference, 17th National Heart Foundation Conference on Cardiovascular Diseases, and be a discussant of the preventive part discussion. The presentation by honorable sirs in light of their experience as well as knowledge is unquestionable, which definitely is enriching us. And with that light, we want to be enlightened. And being middle or new generations, we should move forward with the knowledge of our teachers and the research persons. Now the time has come to be focused on the preventive side. As far as I have learned and understood, as much as I can follow that, curative side, inshallah, Bangladesh has been proceeded, especially in cardiovascular side, highly. And sitting in this center, in this highly honored room, it's known to everybody all over Bangladesh, not only Bangladesh, the international guests are also here. All do know that National Heart Foundation has proved to be the best serving organization of Bangladesh in cardiovascular sector. They are also now focusing on the preventive side. They have done enough, or they have reached the level best, not in perspective of Bangladesh, but also in perspective of developed countries. So they are also telling that, yes, we are now expert and we have done enough, or we will be doing in context of curative side, but it is endless. At the end of the day, the cure, as much I cure, it is endless. The question comes, why it is endless? We are serving so much, but there's no end. The patient's sufferings have not been focused completely by the juniors, or they are not referred properly to the specialized person. One doctor or one specialist is handling all types of patients from bottom to the top level. So doctors are overburdened, or the specialists are overburdened, and patients' sufferings has not been reduced to the extent it should have been. So that's why we have come to the day or time that we should distribute the responsibilities among the levels or layers of doctors, not in light of government or non-government. To prevent cardiovascular diseases, all government, non-government should work together. The disease is for all, not for a government person or non-government person. That's why NCD is working, and now National Heart Foundation is giving us the opportunity to work along with them. And the way that Sir told about the salt, we are taking double the amount of salt of WHO recommendation. And I was just thinking while hearing Sir's speech that how do poor get the processed food? We in the town or cities, we are privileged to have fried chicken or all those processed food. At the right moment, Sir told chanachur, I don't know the English of chanachur, and chips, which is very cheap. The products, the chips of which are made locally, you can get big packs of chips at the price of 10 taka. And nowadays, the problem of hypertension is spreading all over the countries, not it is restricted to the town or the cities. So if we go through each and every risk factor of cardiovascular diseases, it is not for the rich. Hypertension is no more a disease of rich. It is a common disease. And as Sir has mentioned, it is the topmost prior cause of cardiovascular diseases, and easiest way of treatment is the preventive side. The medication for control of hypertension is quite costly. But along with hypertension, we have to count as well as dyslipidemia. While a patient is undergoing under high pressure, the blood vessels are exposed, they are traumatized, and oxidation of the lipids is easy. They become more saturated to be deposited in the walls of the blood vessels. So a patient, before being bound to buy anti-lipid drugs, as also with antihypertensive drugs, government is providing these costly drugs to the patients. But on the patient side, we want to ensure their compliance to the drugs. They'll be ensuring them for the drugs. How? They are not educated. The day they feel with the antihypertensive, oh, my pressure is under control, I need not to take the drug, I'm fine. But hypertension is a silent killer. After reaching some extent, it exposes. When it being exposed, there is time is no more in hand. So we have to teach the patients about hypertension, not about the hypertension only, but about the complications of it. Getting free drugs, they think it's very easy. Oh, I get free drugs. If I have high pressure, take drug. Next day, I don't take drug. But to make the patients learn it, or to make the patients knowledgeable about the risk factors, is our responsibility now. Treating is ongoing process. Curative treatment is not the solution. We have to stop from the root. Without watering the root of the tree, we cannot stop the tree not to grow, at least the toxic trees. If we want to remove the toxic trees, we have to stop watering the root or cut from the root, and that is the preventive side. We have subdivided the preventive sides. We have taken the Robed Amin, the line director, NCDC, is doing on behalf of the DGHS. We compartmentalize. Suppose we are measuring the blood pressure in one compartment. We are measuring the blood sugar in another compartment. Instead of one doctor is doing everything, instead of prescribing the patient all the tests, sector-wise or part by part, if we make the patients more aware, prevention will be easier. Thank you all.
Sir.
I'm going to take a comment from every chairpersons. So I'd like to have a small comment from Robadami and then the Narula. Okay? And Abdullah. In short, I don't have to make any comment because I start with Abdullah in very short. Just
Okay.
few words.
Thank you very much. Assalamu alaikum. Good afternoon to everybody. Actually, I feel highly honored. I'm grateful also to the organizer who has invited me in this beautiful session. Anyway, many of my students also in front of me and my colleagues also here. So I feel very pleased also by looking at them because for the last 2.5 years, for COVID, I could not see your students, friends, anybody. Anyway, today I learned two things, two small words, prem and proms. In Bengali, we know prem, in English called love, but these two are other prem and proms anyway. New things to me. It's a good challenge, two small words, but responsibility is quite high. Another thing about hypertension, actually one problem is undetected, that is true, but those who are detected, that is also a problem. I used to tell my students, also the doctors, at least once you start treatment in any hypertensive patient, counseling is very, very important. Many patients, they are reluctant to take medicine. They say, I'm fine, I have no symptom, I'm all right. Pressure is, I know, I have no problem, so I'll not take medicine. And some others, they take medicine. Once it is controlled, I'm fine, so stop the drugs by themselves. So that is important. You must tell them you will remain better or free from complication. You must take the drug regularly and without consulting the doctors. must not stop the drugs. So few things I tell my young doctors, you must tell to the patient. Thank you very much because of shortest time. So again, I'm grateful to everybody. Thank you very much. Assalamu alaikum.
Thank you, Professor Abdullah, joining us. Thank you very much.
Thank you very much, Honorable Chair, with us discussion and very, very respectable speakers who has been given their skill and I will say that a very knowledgeable presentation. And also the audience, which has been tremendously seeing and listening to the 5 papers we have been there. I think, thank you very much to Inbai. You are always here training the topics in very nice way. The prom and prim actually indicate the social determinant of health. Health is not just a physical issue. There's a mental and social determinant. I think that gives us a impression. And that gives us the impression that in Bangladesh, we need to have some qualitative study in our patients' perspective to identify their psychological aspects, their quality of life. They need to see, check the wellness thing, how far well they are, how happiness index is there, must be seen. This is, thank you, very nice paper. I think it was wonderful to listen to Professor Atik, sir. There was a one saying that after a bond, 1,000 days is very crucial. If you can maintain it, then you can have a prevention of NCD. But I think nowadays, there is one terminology says the life cycle change. Means that we need to change from the pregnancy as big as fetus, followed by infant, then the childhood, and adolescent, up to the age of adult, not the old, is going to be affected the next generation to generations cardiovascular defect. So this is not 1,000 days. Right now, it's 1,000 plus 7,000 means 8,000 days is very important for a life to prevent the generation to generation NCD. I think the third paper was tremendous. Professor Abid, who's been working relentlessly, I would say, on the part of NCD Bangladesh. Thank you very much for your work in the ready-made garments, as well as I have seen your work in the FDMN. Tremendously working he's doing on the NCD part. Hard job, small area, but doing it very comprehensively. Initially started with a lab, non-lab based. Right now it's a lab based. And doing the sun work as a part of their electricity, tremendous. And also at the same time, he's doing a cervical cancer screening, not only part of screening, he's also doing treatment part. We have been very highly focused. I'm just saying that through his team and in HIFA, the non-communicable disease control program, and the government is interested to expand the management model into at least area in the Noakhali as well as Chatpur. So this larger area, when we cover in according to our 180 Upazila, I think it will cover a large part of the Bangladesh for the coverage of the NCD prevention and screening. So thank you very much for your paper. Tom was fantastic, absolutely. We need the things that beyond intervention. There was one saying that any patient having diabetes above 40 years, if he covered with the statins, then the reductions of the mortality will be huge impact. And it is said that if you want to go for the angioplasty, it's the statin, it's the medical angioplasty. And so always there will be a comparison of medical angioplasty versus the PCIs. And I was saying that the target for the 2030, WHO says that for above 40, we need to have 60% coverage of statin in a country. And we have the coverage of 6%. So I think for any 40 years, forget about the doing any cholesterol level. You just have to give the statins forever. And also the combination of polypill, it has been extended in India. I think we should also consider about the policymaker. Can we think about to do it in Bangladesh or not? And last of all, and the best of all, while we are working together, Sohail Raja Chaudhary sir about the Bangladesh Hypertension Initiative. I think this is the one serious model that has been working very good in our country. We have proved it in the 54 Upazila health complexes. This year, we're expanding it to 180 Upazila. If we consider about this 180 Upazila with our HIFA and new other partners who are working, we are almost covering around 250 Upazila health complex in Bangladesh for a comprehensive care of the hypertension and diabetes in our country. But we need to reach our target of 492 Upazilas. And that we need to achieve it before 2030. So that's the reason why the next sector program is very crucial for Bangladesh. The commitment is seriously there for the government as well as NCDC. And listening to all the 5 papers and also seeing my friends, cardiovascular, Dr. Abdul Hanan in front of us, it's a pleasure for me. Thank you very much for inviting me in this. Thank you, sir.
This was probably the most fascinating session today, with so many heavy hitters here, with Abdul, with Sohail, Tom, and Tuhin. I mean, it was outstanding session, and I think the only one thing which I would like you to leave here with was one of the slides which Tom showed today from the Courage study, where he tried to show that the medical therapy is as good as the interventional therapy. I would like to take you a little further here, and I would like to probably, if we have time, I would like a comment from him also. Although we say that the medical therapy, this was a win for medical therapy, in my opinion, this was a failure of both the medical therapy as well as the interventional therapy. 20% hard endpoints in 5 years in 2020 is absolutely not acceptable. I think we need to do a lot more. There is a lot of challenge and lot needs to be done. And I think that is the place where the preventive cardiology is going to be playing a role. So thank you.
Thank you, everybody.
Thank you, everybody. We would like to hand over crest and certificate outside the hall to the speakers.
Thank you once again, ladies and gentlemen. Now moving to our next session, how to deal with calcified lesion. And to chair this session, I would like to request Professor Fazlur Rahman and Dr. Tom Johnson, and also requesting Professor Sabina Hashem, Dr. Manoj Chopra, and Dr. Tamzeed Ahmed to be